So I'm lucky. I've been the team physician, one of the team physicians for the union since they started in 2009. Wow. So about a half an hour before the game, I will then check in with one of the national athletic trainers who is in our offices in Texas, where they're basically our eyes in the sky. So I'll be on a headset during the game. And so we'll check in, make sure everything's okay. We'll go over what we're looking for from a concussion standpoint, a sports-related concussion standpoint. And so they'll be my spotter, basically.
So welcome to the Move Room. I am your host, Dr. Catherine Reber. I'm a physical therapist out of Kinetic Movement Reimagined, located in Westchester, Pennsylvania. And today we have a very exciting guest, Dr. David Webner. Dr. David Webner is a board-certified, non-operative sports medicine physician and has special interests in concussion management and brain injury. And really cool, he works with some sports teams in the area, some that you may know, but he works with the Philadelphia Union of Major League Soccer and also works with Webner University and some high schools in the area as well. So thank you so much, Dr. Webner, for joining us today.
It's good to be here.
I know, this is great. Excellent. So tell me a little bit just about your background. Like, how did you even, before, going into the sports teams, how did you even get into medicine?
Yeah, so getting into medicine and getting into sports medicine were kind of not on purpose necessarily.
Yeah.
I knew I wanted to do medicine in college. I didn't quite know what kind of physician I wanted to be. So I actually went to medical school in Israel at an American program there in Tel Aviv. So I did that for 3 years. Then we did part of our fourth year in the States. And then I kind of decided I didn't really know what I wanted to do. One thing medical school does is it gives you the tools to become a physician, but it doesn't necessarily give you a lot of time to decide what kind of physician you want to be because you're doing a ton of rotations and all sorts of disciplines. And so I was kind of really undecided. So I decided to do pathology, which I liked during medical school, but certainly not necessarily a communicative specialty. So as soon as I kind of started, I kind of realized that it wasn't really for me. And so a couple of years later, I shifted gears and I started doing family medicine residency at Penn. Yeah. So I completed that. And, really, I just kind of wanted to be a general family practitioner, general family medicine. Didn't want to necessarily specialize. But when I started in my second year, we brought in a new faculty member from the University of Washington. And he was the first person I kind of met who was a primary care sports medicine physician. He's kind of famous in our field, actually. John Dresner. He used to be the president of the American Medical Society for Sports Medicine, and he's very well thought of on a world stage for doing screening EKGs in athletes. So he's really kind of revolutionized that field. So, but I didn't, I knew nothing. I didn't know who he was when he came. I mean, he was a young attending when he came a couple of years out of fellowship. So he got me really interested in it. So I did a lot of game coverage that year. I really got into the non-op sports medicine side of things. And, I was hooked. I played a lot of sports growing up. I still play. What do you play? I play basketball. I do a little running.
Nice.
So I was, competitive, like playing sports and, obviously interested in injuries and, illnesses with athletes. And then it was just kind of a natural fit and kind of everything kind of fell into place. I did my fellowship a couple of years later at what was then Crozier Health.
Rest in peace.
And rest in peace. And so I did that fellowship for a year from 2003 to 2004. And then I went back to Penn to join John as another sports medicine faculty doctor. But unfortunately, he decided to leave and go back to the University of Washington. So it was me alone. I joined Brian Sennett, who was the head of sports medicine, orthopedic surgeon. And we were kind of the only two sports medicine folks at the time. And so, I did that for a few years, part of the residency program as well. And then I got the opportunity to go back to Crozier to become the assistant fellowship director with Dr. Steve Kalina, who was one of my mentors when I was one of my faculty members when I was a fellow. So I replaced Ryan Scheipel, who's kind of a well-known regional, kind of the first guy to start sports medicine fellowship in the Philadelphia area. So he did that in the late 90s. So I was a fellow under him and Dr. Kalina, and then I went back and joined Dr. Kalina, was with him, became the associate director, became the co-director of the fellowship, and then eventually was the director of the fellowship in 2014. Maintained that role until I left Crozier in 2024.
So recent.
So recent. Right. Yeah, so when Crozier was kind of trying to transition out of the national organization they belong to. They sold the sports medicine department, which was me and 2 other physicians and the 3 fellows that we have every year. They sold that department to Premier Orthopedics. Things kind of went not exactly as we thought they were going to go. So I was fortunate to get a position at Virtua in South Jersey. And join 9 other non-operative sports medicine docs in a huge reconstructive orthopedics and sports medicine practice. Consequently, 5 of the other docs there, 4 of them I trained, and the 5th one did the fellowship I was in a couple of years after me.
Amazing.
So kind of going home.
I knew everybody,
going to a new place, but kind of going home.
Interesting.
And so that's been kind of my career trajectory. I was able to continue taking care of the union, kind of reunited with Dr. Sennett, who's the chief medical officer of the union, and he was kind enough to keep me on with them. So I joined he and John Vasudevan, who's a primary care sports medicine doctor, who's physiatry as well too. So he and I are the 2 non-operative sports medicine doc, and then Brian Sennett's the chief medical officer in the orthopedic sports medicine doc. Yeah.
So how does that work at Virtua? Because you said there's 9 of you that are non-op physicians.
10. 10. I became
you're the 10th.
Yes,
okay.
I'm the 10th.
So does everybody kind of have their own little specialties or kind of things that they see? Or is it kind of once you book an appointment, you can see anybody?
Yeah, I mean, we all do have little specialties. I mean, some people like taking care of sports concussions. I like that. Some people do some minimally invasive procedures, which I do. TenJet or 10X tenotomy.
Sure.
Those are 2 types of tendon debridement procedures. And so I think about 3 or 4 of us do those. We also do a cryoneurolysis, which is a kind of a nerve freezing procedure for people with kind of end stage arthritis that can't get surgery. Or preoperatively, so that post-surgery they're not in as much pain. So we do that. We can do that for shoulder arthritis as well too. So we can do that cryoneurolysis, which is also called iovera. That's the brand name of the company that produces this kind of nerve freezing procedure. So 2 of us do that. We do PRP. Probably about half of us do PRP injections as well. And aside from that, I mean, generally we'll see, everything from the head to the toe. We do have a big hand department. And so they see a lot of the hand stuff that we can see, but they tend to do that. And then we have a big foot and ankle department as well too. And so they see a lot of the foot and ankles, but I end up seeing a lot of Achilles and plantar fascia because that's one of the most common utilizations for the TenJet and 10X debridement procedure.
So you're seeing everybody. It's not just athletes.
I'm seeing everyone. I would say, a third of the practice are like athletes, a third are weekend warriors, and a third are older patients with arthritis.
And then how does that work with, of course, the physicians that do surgeries and stuff? Do you guys do a lot of talking between them? If you have somebody here, like, this is not going to work in a, conservative management, we got to send you out. Is there another Virtua group that is pretty much orthopedic?
So they're part of us as well. So under the Virtua Reconstructive Orthopedics and Sports Medicine umbrella are joint surgeons, trauma surgeons, sports medicine surgeons, and then the physiatrists, the physical medicine rehab docs, us, the non-op sports medicine, and then we have a huge hand service as well. And so a lot of different, and then podiatry, as I said, a lot of different folks under the umbrella, which is nice because you can talk to a shoulder surgeon, or you can talk to, a knee replacement surgeon. So you always have those people kind of at your beck and call. I mean, I'll give you an example. I saw a lady, an 83-year-old lady, really healthy, really active. She slipped and fell. I was seen in the ER a couple of weeks ago. They did an x-ray, just to make sure her hip wasn't fractured. I see her for hip arthritis, so do injections here and there under ultrasound guidance. So I use a lot of ultrasound guidance too. So about 4 or 5 of us do a lot of ultrasound guided and ultrasound diagnostic treatment because that was a big part of our fellowships. So I saw her and, she was still in a lot of pain. And for my exam, I kind of was suspicious of a non-displaced, kind of an occult hip fracture. And so I talked to one of my joint replacement colleagues and we kind of set up a plan and, she had an MRI, which showed a non-displaced femoral head fracture. And so he saw her the next day and he's setting her up for joint replacement. So it's nice to have everyone, to have people really right at your beck and call.
Absolutely. And just be able to work as a team. I love it. Before we move on, so you said you played basketball. Did you play in college or
I did not play in college.
You're very tall.
I played in high school. I did not make my college team.
Oh, man.
But I continued to play a lot. And so I actually played twice, or actually 3 times in a international basketball tournament. The Maccabi Games are basically the Jewish Olympics.
Yeah.
And there's some regional and national and international. So I did the Pan American Maccabi Games in Santiago, Chile in 2014.
Oh my gosh.
And then I did the big Maccabi Games, which is in Israel every 4 years. I've done that twice. I think I did it in 2017 and then 2022.
Awesome.
Yeah, so
That's so cool.
There. Yeah.
I was a terrible basketball player. I used to play in high school, just like recreational games. And it got to the point where the other team like felt like, we were all trying to score and the other team handed me the ball and then no one guarded me and they just let me go shoot. Like I was in kindergarten.
Nice.
So you'll have to teach me some skills later. Horrible. Have you ever been concussed yourself?
Yes.
In basketball?
I have. Not in basketball. It was a non-sports concussion.
Oh, geez.
Actually, that's not true. There's a sports kind of a sports motif with it.
Okay.
So I was 4 years old.
Okay.
And I went with my father. My father played squash. So I went with him and a friend of his to play squash. And it was one of those kind of older time squash courts where they have like a balcony above where you can kind of watch the players playing. Okay. And again, I was 4. So, as 4-year-olds do, they climb balconies. And so I climbed up and then fell right down. Yeah. I landed on the court, landed on my head, and took me to the hospital. Luckily, I was still conscious.
Like a skull fracture?
No skull fracture. Everything seemed to be fine. And I was discharged like a week later.
Oh, my gosh.
So that's my first. It's not really a sports concussion. It's a concussion, but it was involved with sports, right? So I was watching sports, and I got a concussion.
That's pretty bad.
Yeah, that's my big concussion.
Oh my gosh. So, yeah. I know. We'll get into it, but I've also had quite a few concussions and I'm like, how many is too many? But we'll get to that. So let's talk about the Philadelphia Union. Sure. So how long have you been working with the Union? Yeah, so I'm lucky. I've been the team physician, one of the team physicians for the Union since they started in 2009. Yeah. Oh my gosh.
So I've been there for quite a while.
I don't think I really realized it was that recent that they've... Yeah,
we started assembling players in 2009. I think our first season was 2010, if I'm correct. Yeah.
Did you have to help pick
the players? Oh, no, not.
You're like, I want that guy.
I do. We did the physicals for the players.
Nice.
And occasionally they'll have us pre-see a player before they're interested in signing them or not, just to do a medical on them, just to make sure they're not getting damaged goods.
Okay, awesome. So take me through a game day. So when you go in for the game day, how early you get there?
Yeah, sure. So a game day, I get there about an hour and a half, 2 hours before the game. Occasionally there's athletes to see, issues to take care of prior to the game. Then at about an hour before game time, we meet the medical team and then the Philadelphia Union attaché and whoever they're playing meet together with the match coordinator and the fourth official before the match. And we kind of go over kind of the logistics of the match, whether there are any medical things that we have to, be kind of tuned into. So during the summer, because we play a lot of our matches during the summer, that's going to change in MLS. So starting next year, they're going to go to the same schedule that the European leagues do. So they're going to start in August and end in May. Right now, we start in February, March, and end in November. So we will miss that huge piece of summer.
Why the change?
Yeah, I think they want to be on the same schedule as the bigger leagues in the world, and just so with transfers of players and stuff, they'll be on the same schedule. And so if it's a really hot game in the summer before the kickoff, we'll talk about we'll get hydration breaks, we'll talk about some logistics that might happen. Yeah. So that's an hour before the game, and then we'll go out with the team to warm up. So about a half an hour before the game, I will then check in with one of the national athletic trainers. Who is in our offices in Texas, where they're basically our eyes in the sky. So I'll be on a headset during the game. And so we'll check in, make sure everything's okay. We'll go over what we're looking for from a concussion standpoint, a sports related concussion standpoint. And so they'll be my spotter basically. During the game. And, I'll have a monitor in front of me. Again, I'm watching the game, watching the monitor kind of at the same time. And then if anything happens, I'll be able to watch the monitor review for any mandatory signs for concussion. And then we can evaluate the athlete.
So basically, if you miss something going on, you have those people that are watching the game to be like, Dr. Webner, Oh, that guy.
You gotta see that guy, right?
Interesting.
And then about 20 minutes before game time, we meet with the emergency medical personnel on the field, the two athletic trainers, or any athletic trainers that travel with the away team, and our two athletic trainers meet with the fourth official and the team physician, so the orthopedic surgeon and the venue medical director, which is me. Mm-hmm. And then occasionally, if there's one of the physicians traveling with the team, they'll also meet with us. And so we go over the emergency medical plan, which hospital we'll be taking the patients, we'll be taking the athletes to, if there are any injuries, if there's really any severe injuries, which hospitals have those capabilities. Okay. So, the one dreaded injury that every sports medicine doc dreads is, sudden cardiac arrest. Sure. So luckily we have Penn as the medical provider for the Philadelphia Union. And so we have one of the few regional places that has 24-hour ECMO. ECMO is a machine that you can put people on who are have had cardiopulmonary issues, and it can basically, work to help them
it's like acting function. As their heart.
Yeah, heart, lungs, everything. So more like ECMO is more like a lung type thing, but it can help keep them alive for a while we're doing other things.
Wow.
And so we have that capability. Hopefully if there's, God forbid, if there's ever an arrest on the field, we'll be able to get that player back with, an AED and quick kind of sudden cardiac arrest protocols.
Have you ever been on the field when that's occurred?
I haven't, but I've been the director of a sports event where that happened out in the field. We had two interns there who, a baseball player catcher took a foul ball off his chest protector. And much like DeMar Hamlin of the Buffalo Bills had a commotio cordis. Sure. And so luckily my two interns were on the field. They started CPR right away.
Unbelievable.
Another one of the attending physicians was in a golf cart around the complex and was able to get the AED there. And they got the AED on the kid within 3 or 4 minutes. And then 3 days later, he walked out of the hospital.
Unbelievable.
Yes. So that's one event. I was also at another event where I was also the medical director.
Love the responsibility.
Yeah, right. And one of my fellows was at a finish line tent. We were doing the rock and roll half marathon in Philadelphia. And one of my fellows was at the finish line tent, and somebody collapsed right before the finish, about a 52-year-old guy. She also started CPR. She got the AED on. And about a week later, he walked out of the hospital.
Unbelievable.
So, he had a cardiac arrest as well, too. So
it's really one of the most important things is like the immediate intervention.
Yeah, right? You want to make sure the emergency action plan is, and we rehearse the emergency action plan for the Philadelphia Union. So we'll rehearse it about a week before the season starts and then midway through the season as well, too. Okay. So drill is very important for the emergency action plan because you just want to make sure that you know what you're doing when when everything is chaotic.
So I'm sure adrenaline takes over and you just want to make sure it's just routine work. You've been there, you've done it before. So tell me a little bit about who's on the medical team for the union. Who are you working with on a daily basis?
Yeah, no, that's a good point. We will do a training room every week. And so there's 3 athletic trainers, the head athletic trainer, the second in command, and the third athletic trainer. Okay. And there's a physical therapist who also happens to be our head of medical. Okay. So he's the head of medical. Underneath him are the athletic trainers, the medical side, and then he's got the performance side. So there's 2 performance strength and conditioning coaches as well. And then the coaches. And then the coaches kind of work in concert with the athletic trainers. And I like to explain to folks that the athletic trainers for the Philadelphia Union are more kind of like primary care physicians for the athletes, right? So they see everything. They treat them from colds to ankle sprains to, sprains in the neck to muscle spasms. So they'll treat everything. And then they'll kick it up to us, the specialist, if there's anything a little bit out of their wheelhouse.
Sure.
So they really probably manage 90% of what goes on, maybe even more. Okay. And then we kind of see the stuff that, needs a little bit more attention. And so it's the coaches that work with them, that work with the performance specialists, trying to find out how much training the union need, when they need days off, what kind of training it should be, high intensity, high energy, low intensity, that kind of stuff. And so everyone kind of works together to kind of put the product out on the field.
That's awesome. Yeah. Okay. Tell me a little bit more about Webner. So how does this differ in terms of like a professional level sports and then the collegiate level, or is it different?
So no, there are differences, sure. So I am the team physician for Webner. I see patients there once a week in the student health center. And that student health center is run by 3 nurse practitioners, and then I'm the physician consultant. And so I'll see mostly athletes the day I'm there from all different sports. And at Webner, we have 4 athletic trainers that are also, again, our eyes and ears out there. And so they send us athletes that they, need a second opinion on or need help with. And then as far as game coverage, I'll cover Webner football.
Okay.
So they have about 5 or 6 home games. And so I'll cover Webner football on the sidelines. And obviously there's a lot of, football's a high intensity, high collision sport. So it's, there's a lot of work that usually goes into covering football.
Sure.
Having to go on the field for various injuries during the coverage.
Absolutely. So. Do you see way more concussions in football than you do with the union?
Yes. Way more.
I can't even imagine.
Yeah, I mean, I would say probably once a week we have a concussion.
Oh, geez.
Yeah, so it's pretty frequent.
Yeah, that's amazing. I could only imagine. So let's start. I just want to walk through of what the protocol is. So let's say somebody out on the field gets a concussion, whether you saw it, whether one of the people in Texas, you said, whether one of them saw it.
Yep.
What happens next? Do you guys?
Yeah, I mean, so the protocols are a little bit different. We have a rigid protocol that we have to follow with Major League Soccer.
Okay.
And then we have the standard protocol that we follow with Webner.
Okay.
And so they're slightly different. So normally the athlete will go down, we'll see it on the monitor. There are things called mandatory signs, and then there are things called observable signs. The mandatory signs are ataxia or abnormal gait, loss of consciousness, seizures, impact seizures on the field, intractable vomiting, and so neck injury, that kind of stuff. So for those things, we have to go out and evaluate the athlete. Okay. And the athlete actually has to be removed from play to do a full evaluation. So
are you typically going out to the field, or they bring them to you?
We go out to the field.
Okay.
So you want to make sure that they don't have any neck issues, because you don't want to move an athlete if they have a neck issue, or if they have a neck issue that could potentially be cervical spine injury. And then so you assess that, airway, breathing, circulation. You do the ACLS, or the advanced life support kind of check first. And then, if you ascertain that it's a concussion, or you think there might be a concussion, and there's any of those mandatory observable signs, lying motionless, loss of consciousness, seizure, things like that, falling floppy to the ground, those people have to come off and do a 15-minute full evaluation. Okay. And then they are out of the game unless you can find a reason for why they had that. So maybe they sprained their ankle. That's why they were walking funny. Right. So most of the time the people will leave and not come back. Major League Soccer was the first league to have a permanent concussion sub. Okay. So if we're evaluating a patient, we take them off the field, the team is allowed to have a concussion substitute for that athlete.
Okay. Interesting.
That's outside of the regular substitutes.
Right.
And then the opposing team gets an extra substitute because the other team's using the concussion substitute.
So do other, like the NFL and all these other leagues, do they have the same thing?
So that's not an issue with those leagues because they have subs in and out, right? So people can go in and out. The gold standard would be having a temporary concussion substitute, right? So I could bring everybody off. I could evaluate them. I'd get 5 to 10 minutes, and I'll tell you in a second why that's important to evaluate them. And if they were fine, then the guy who's substituted for them, we can now take him off. So temporary concussion substitute would be the amazing thing if we could get that. But soccer is a sport that's been around forever, and their big thing is little to no interruption in the game.
Of course.
Right? And so what normally happens, we also go out to the field for observable signs. So the observable signs are not mandatory signs that they have to be removed, but they have to be evaluated on the field. Quick evaluation, anywhere from 2 to 3 minutes. So those observable signs are clutching the head, going down after a collision, slow to get up. Signs like that don't necessarily mean there's a concussion, but that may mean that. So that we'll go out as the venue medical director. We'll watch the video for any mandatory signs, and if we don't see those, but we see a decent collision, and the player goes down and has difficulty getting up, or doesn't get up after rubbing their head or anything like that, then we'll go out. We'll evaluate them with the athletic trainer, either of the home team or the visiting team. So we act as the venue medical director for both teams, and then we'll evaluate them, make sure there's no mandatory signs, make sure they're doing okay. We'll bring them off the field, and then we stress them. We do a stress test on them, which usually consists change of direction, sprinting, having the head change direction to make sure that we're not getting any symptoms when they do that. Because adrenaline does kick in after an injury like that. You can kind of mask the symptoms, which is why, that gets me back to the temporary concussion rule. So we know, based on the research that we've done at MLS, that it can take up to 10 minutes. Actually, it can take up to a few days before the concussion symptoms can start. But certainly, if you're able to wait 10 to 15 minutes, you can see concussion symptoms begin. And so a lot of times, we don't have that luxury. We have to make a decision in 3 or 4 minutes. And if we say, hey, they have a concussion, they're coming out, the concussion substitute's going in. Right. And so that's an issue.
Yeah.
We don't necessarily have time unless there's a mandatory observable sign. They're usually coming out anyway. But most of the concussions that I see, about 50% of them, I take them off when I see them.
Sure.
So, and then the other half don't have symptoms until 5 minutes later, 10 minutes later in the second half, and then we take them off. So, our goal is to get them off before they kind of continue playing, but it's hard to tease out whether they have symptoms or not. If we had a waiting period, 10 or 15 minute mandatory waiting period to make sure that there was no concussion symptoms developing, I think we'd get about 80 to 90% of the athletes before they went back to do additional. Because obviously putting somebody out there who has symptoms or is about to have symptoms can be potentially very dangerous.
Sure. So out of like the mandatory observable signs, are there, a collection of one or two symptoms that when you see it, you're like that's going to be a bad concussion, or that may lead to a longer recovery? Yeah.
So you can't. So the one thing about concussions is you can't really predict the severity. So, early on in the 80s and 90s, when we were first realizing the seriousness of concussions, they had a bunch of concussion scales. So we would grade them 1, 2, and 3. Now we don't grade them at all because you could have somebody with what appeared to be a mild kind of concussion, no mandatory signs, just some observable signs, and they could be out for 3 months with a headache that doesn't go away.
Right.
You could also have somebody with a mandatory observable sign who has loss of consciousness, and then they're off, and within 3 days they're symptom-free.
Interesting.
So it's not always kind of cut and dried as to what kind of concussion it is. But generally, if I see somebody come up and then basically fall unprotected to the turf, I'm pretty sure, I'm running out there before checking the video.
Right. You're out.
And then obviously if somebody gets up and then starts staggering around, I'm running out there or checking the video. So those are kind of the things that we kind of look for.
And then do you think it matters? Because essentially maybe tell them what a concussion is, right? Like it's the movement of the brain in the skull.
Yeah.
Do you feel like it's, depending on where they got hit, whether it's in the back or in the front or in the side, do you notice an association between where they were hit and what kind of symptoms they may have?
No.
Or does it's just
because it's it's usually a rotational. It's not like a one type of movement in the brain. It's usually a rotational movement.
Right.
Yeah. So, there's not specifically one association with where they've been hit.
Sure. Another question I have is, do any of the players give you guys any of a hard time? Like if they clearly have hit their head and maybe they have a couple symptoms, but they're like, I want to go back out on the field. Does that ever happen?
Yeah, of course.
Because of course athletes are athletes. They're going to want to play through no matter what.
Right. So MLS has really made it a priority. Brain health is really a huge priority for them.
Absolutely.
So I think about 15 or 20 years ago, they really instituted, players had to watch a video. There was a culture shift because there were a few high-profile MLS players whose career ended because of concussions and post-concussion symptoms.
Yeah.
And so, MLS as a league got together to really make brain health a priority. So, by and large, nowadays, if somebody goes down and it looks severe, more often than not, I get their teammates calling us on the field knowing that there's something wrong. And, a lot of times the teammates will call on even if there is not something, so the teammates really kind of look after each other. They know now that if you come off with initial symptoms and don't continue to play through, you're going to get back much quicker.
Yeah.
So one of the risk factors for prolonged post-concussion symptoms is if you play through or play with a concussion. So if you stay in the game with those symptoms, then it could potentially take more time to come back from the concussion. Yeah.
Do you feel like this goes for, whether it's union or whether it's all the athletes that you're seeing at Webner, do you feel like there's certain populations that may be at risk for a prolonged recovery, like whether it's female athletes?
Yeah, so female athletes have been shown time and again to have a little bit more of a prolonged recovery. And so we don't really know why. It could be because they're more honest about reporting symptoms. It could be biopsychosocial issues. Don't know why they would be more prone to that. People with learning differences, people with attention deficit disability or attention deficit disorder can take longer to kind of return to play.
Sure.
Also, people who had previous concussions, that's always a marker for length of symptoms.
Yeah.
And then those people that I talked about, those people that go back, that have the symptoms, go back and return to play, don't tell anybody, they can take longer to heal as well.
Okay. What are some of like the neurocognitive symptoms that you see? So like the memory, reaction time, processing, what kind of
Right. So, there's 22 major symptoms that have kind of been teased out over the years that's the symptom checklist that we get everyone. And we give everyone, they're in different kind of groups. So you get headache, head pressure, nausea, dizziness. That's kind of one group. You get a group of, difficulty sleeping at night. So there's like those sleep-centered questions. Then there's that, as you mentioned, difficulty concentrating, difficulty remembering.
Right.
There's some psychosocial ones, so irritability, anxiousness, nervousness. And then there's some visual ones, so blurriness, light sensitivity, visual changes. So there's really the whole spectrum of kind of brain symptoms that you can get from a concussion.
Okay, interesting. When you were 4 and you fell off the balcony, do you remember any of these symptoms?
I remember none of it.
Maybe that's for the best.
Maybe
more traumatizing for you. You said you were watching your dad?
Yeah.
More traumatizing
for him. Yeah, absolutely. Sure.
That's crazy. Okay, awesome. So let's talk a little bit more about any other like diagnostic tools that you're using or, other gold standard testing or certain things that you kind of run through when you're evaluating the player.
So, the International Consensus Statement for Concussion, the most recent one was in Berlin, the SCAT-6, so the Sideline Concussion Assessment Tool, the sixth kind of version of that. There have been multiple international consensus conferences. The most recent one was a few years ago in Berlin, as I mentioned. And there's also the SCOTE, which is the office assessment, the standard concussion office assessment tool.
Sure.
There's a child SCAT, which is, for kids less than 12. They've also managed to make kind of the assessment tool can be used as a baseline.
Okay.
So for the union, we use a modified assessment tool, a baseline assessment tool that we give everybody. And then when and if they're being evaluated for concussion, we then compare it to their baseline.
Okay.
Now, there's a lot of neurocognitive testing out there, computer-based neurocognitive testing.
Sure.
There's a bunch of different companies that provide that. One of the most notable or most famous companies that's been doing it for the longest is Impact, which is one of the neurocognitive tests, about 20 to 25 minute neurocognitive test.
Sure.
And so at Widener and with the union, everyone gets a baseline impact.
Okay.
If they do end up at the union, if they do end up getting a concussion, they'll take a repeat impact test once their symptoms have cleared.
Okay.
And then we have a neuropsychologist, sports neuropsychologist that we work with. And so then they'll do paper and pencil testing.
Okay, gotcha.
As well, which is like a hour battery of tests to make sure they're neurocognitively intact.
Do you personally do like any vestibular ocular motor testing or like convergence testing? And maybe describe what that is.
Yeah, so I do those tests. I did a study with my colleague Kevin Dupre, who worked with me at Crozier Health. We did a study on convergence. We took baseline convergence, which is the distance from your eyes until your fingers get blurry.
Right.
And that's the accommodation.
Right.
So as your fingers come close, you're able to accommodate, you're able to see that. And we found that almost all concussion athletes have lengthened convergence. And so you can actually watch them as they get better, as their symptoms decrease, the convergence.
They'll be able to see it.
Yeah. So athletes that are, middle school through high school, their convergence is 2 to 4 centimeters at baseline.
Okay.
As we get older,
that's what I was going to ask you.
Folks in the room here, their convergence becomes much greater.
I don't know if I can see.
And so some of the older people in the audience listening, with their readers and everything like that. So
I love that.
I should say with our readers, because I'm in that population as well too. So that's what, so we'll do that. In addition, there are saccades, which are side to side eye movements, vestibulocular reflex, which is basically looking at a moving target and focusing on that, looking for symptomatology in those two tests. And we do a cranial nerve assessment as well too. There's multiple types of physical assessment. We'll do a full neurological exam on the athlete as well. We'll have a section of cognitive questions that we do kind of as a baseline before we send them to a full neurocognitive battery of tests. And when we see the athlete first, they always get a concussion checklist. Okay. So those 22 symptoms we mentioned. And that's another thing that really goes with prolonged post-concussion. So the higher their symptom load, a week, 2 weeks, 3 weeks out after the injury, the longer it's going to be for their recovery. Okay. The other important thing, John Leddy, who's a sports medicine physician at the University of Buffalo, has come up with whether physical activity is good or bad after a concussion. He's proven that early entry back into non-contact exercise, 30 minutes of light exercise a day has been proven to show to decrease the time course of a concussion.
Interesting.
So we use that, in the old days, 70s, 80s, 90s, you'd put somebody in a dark room, right? They don't see or talk to anybody. Nothing. So now we want to get people back doing things, not too much, but doing things. So I try and get people back on their screens and their phones within 24 hours. Just tell them to monitor the use 5 or 10 minutes unless they get symptoms, then they kind of back off. And then we talk within 24 to 48 hours, getting people doing that light exercise.
So is this more like an active rest? Like they're still doing something, correct, just not back to their sport and going crazy?
So that takes a while, obviously.
Okay.
And then, the newest guidelines show that as your symptoms decrease, you can start return to play. You just can't do any contact. So you can start with some sport-specific drills, and start with some, higher intensity cardiovascular exercise. Okay. And then until your symptoms are clear. Once your symptoms are clear, generally we do an impact test. If they pass that, we send them back to contact sports if they're back in the return to play protocol, the 5-day return to play protocol. And then once they've passed all those levels, in other words, they haven't had any more symptoms, then they can return to play.
Okay. And when they're doing that initial active rest recovery, do you feel like it's more important to do more cardio type of exercise or more resistance training, or what do you suggest?
Yeah, so for me and for what I think a lot of people do, heavy resistance training is akin to contact, really. So that comes last. That is a question that, especially, in a lot of the strength type sports, so wrestling, football, things like that, they ask, can they get back to weight training right away? And that's actually the last thing I let them do.
I see. Okay. So it's more so walking.
So cardiovascular, jogging. So walking to jogging to maybe doing a little bit more intense activity, and then doing sport specific things, then doing non-contact drills, then getting into contact practice, and then gameplay. Okay.
So what is that? You mentioned the 5-day return to play.
I just gave it all to you.
Oh, that is the return to play.
That's the 5-day return to play.
Like, what is it?
Right. So light exercise first.
I see. Okay. So it kind of goes through that.
It goes through that.
Okay. I wasn't sure if there were like other drills and things that they had to pass.
For different sports, there's different things. So for soccer, part of the contact when you're getting back to contact, is we do some heading. Okay. We have a softer ball that we first head closer. And then, we'll do farther and farther, and that they have to get that before they can go back to gameplay.
I see. Yeah. Okay, cool. Excellent. So let's talk a little bit more about, you mentioned like the non-interventional stuff, so like the screen time and stuff like that, because I know that was always a big thing, even when I started PT, of, okay, maybe don't use the screens and stuff like that. What's the hardest non-interventional strategy that is difficult for people to stay away from, do you think? I know it's kind of a weird question.
You mean, what should they avoid?
Yes. Out of all things, what do you think is one of the toughest things to get people away from?
I just think there's a stepwise approach to going back to, I think people want to move faster than they should. Absolutely. Right? They want to get back to school. They want to start doing testing. They want to start doing homework. Because once you get back to school, then you can think about getting back to sports.
Sure.
And so I think they push themselves a little bit. Okay.
What's the longest concussion recovery timeline that you've seen?
I've had athletes who've never fully recovered.
Wow.
Yeah.
That's amazing.
So have developed migraine headaches, have developed other symptoms over time.
Is it something that they can't return to sport at all?
Many of them, or they can't return to contact or collision sports.
Okay.
Yeah.
Have you seen it more in the soccer world or more?
No, in every
realm.
Yeah.
Interesting.
You can get it in any, obviously in the more contact collision sports, you'll see people like that more frequently, but it can happen in any sport.
Okay. Have you ever seen skull fractures?
Yeah, concussions can go with that, but the definition of concussion is there's no structural brain injury, no skull fracture, no vascular injury, nothing like that, no subdural or epidural hematoma. So we've seen that. And ironically, skull fractures actually, in many cases, people have a skull fracture, people have nasal fracture, any other facial fracture, zygomatic fracture, they tend to have less symptoms of concussion. And that's most likely because the bone has kind of absorbed a lot of that. The bone stress has absorbed a lot of the forces. And so we tend to not see them have prolonged concussion symptoms.
Okay.
So obviously they have other issues they have to deal with.
Sure.
When you're talking about facial fractures and things like that. But that seems to be something that they don't have to deal with as much.
Okay. Can you talk to me a little bit about prevention? Are there certain programs, like even like proprioception training, neck strengthening, postural training? Are there things that you can do to prevent the risk of a concussion?
All those things you mentioned, proprioceptive training, vision training. There's a few college football teams that have a vision board, so they're able to see hits coming more quickly. You can train yourself to see peripheral, things like that. So that's prevention. The NFL instituted some things like minimizing the tackling during proper types of tackling techniques that don't, shake the head as much. They wear what's it called?
Is it the thing over the helmet?
Right.
I was going to ask you about that.
Padded Guardian helmets, which have shown some data. There's no data to prove that they decrease the amount of concussions, but there's some data to show that they can limit the amount of impact.
Yeah. was going to say, there's so many things out nowadays. Like I've seen the
neck collar. Those
in
also,
lacrosse. I've seen the headbands.
So the neck stuff is also worn by football players as well.
Okay.
And that basically just increases blood flow. It increases, it's supposed to, the theory is that you increase the amount of fluid, blood flow there that can help kind of cushion the brain. There's no, well, I mean, I can't say yes or no because there's no data that's proven that it decreases incidence of concussion. So we don't have that yet. We don't obviously have a helmet that decreases the incidence of concussion either. I mean, I think, prevention's one thing, the tackling. The one thing that has been shown to reduce the amount of concussions is starting hitting in hockey over the age of 14. So they did away with hitting under the age of 14, crashing up against the boards, and that dramatically decreased the amount of concussions. So that's one thing that has been shown to dramatically decrease concussions. Some people think that wearing mouth guards might be helpful. That hasn't necessarily been shown. That hasn't been proven to decrease the incidence of concussion. So I think identification is the most important. Yeah, we could do some of those prevention things, but I think identification and early detection are the most important things.
Absolutely.
And once you get them out with those initial symptoms, they can come back. They tend to pass more quickly.
Yeah. So like you were saying, soccer's been around forever. Do you feel that the concussion rate, do you feel like it's been about the same over all the years? Do you think it's worse?
I think, I think people played with the injuries more so in the past. So identifying it earlier and taking those athletes out. I think probably the incidence and prevalence is probably just as much as it was. I just think that we didn't diagnose it.
Sure.
So that's why it appears less.
And then will they give red cards to players that are being too aggressive on the field, especially if they're getting too close with?
Yeah, I mean, I think any head trauma in our league that is intentional is a straight red card. Okay. And then, putting players in danger is either a yellow or a red as well.
Is that the same in Europe?
Yeah.
Games? Okay.
Yeah. Okay. Yeah, that's pretty much the same around the world.
Okay, interesting. Let's talk a little bit about CTE because I think that's a big topic right now in terms of the diagnosis. And one of my questions is, does it get diagnosed only post-mortem or,
Yeah, it's only a post-mortem diagnosis. It's kind of a controversial issue within the sports medicine world. There haven't been any randomized controlled trials. In other words, the best thing you could do, the gold standard of a research study, would be to examine brains of athletes who are in non-contact sports, athletes who are in contact sports, athletes who are in collision sports, and people who aren't athletes, who didn't play any sports. Right. So you have to have multiple groups that you take, that you examine, so a post-mortem examination of the brains in multiple groups. And then you have to kind of follow that out to see what changes are seen on the brain and whether that correlated or not. Right. So, we know that amyloid plaques, neurofibrillary tangles are seen in people who've had massive head trauma. Right. But the question is, in somebody who's gone through their whole life and, hasn't had necessarily any issues, do they also have those changes in the brain? Because if they have those changes in the brain, then we're not, that's not correlative.
That's so true.
Right? And that's not causal either. And so all we have really right now, there's a few groups in the country, in the U.S. especially, that collect brains, collision athletes who have died early or even who have died just from natural causes to look at the brain architecture. And the microvascular architecture. So we know that, yes, they have changes, but we don't know what Joe Schmo or John Doe changes are in those. So we don't have that. And so I think that's a major knowledge gap that we have looking at CTE and whether contact collision sports are, we know they're a factor in CTE or, in concussion, prolonged concussion symptoms. We know that they're a factor. And obviously we think that somebody who's a runner versus somebody who's a collision athlete has more of a chance of developing post-concussion symptoms and then potentially CTE. But we haven't really done, I think, great science and great evidence-based science to prove, the load that I know you're going to ask about. Amount of concussions, right? We don't even know what the litmus test is. We don't even know if certain people can have less concussions than others. So there's a lot of knowledge gaps, a lot of things that we have to continue to probe into in order to really, understand what goes on after a concussion.
Do you think that is part of what will happen in the research world eventually? Do you think that's something that they will look at, is kind of going through all of those different control groups, if you will, and then the groups that may be exposed to, the collision sport athletes that are getting, they may be at high risk for concussion?
I mean, I think eventually things shake out like that. I think it's a sensational type of a news story when somebody, dies young and they have a collision sport. So, did they have CTE? And so people, that's a big news story, big headline.
Yeah.
And so I think that's what the researchers gravitated towards. Right? That's what people give money to. That's an easy, low-lying type of research, but it's really not double-blind, control trial, all that stuff.
Yeah.
And so, I think eventually we'll get there, but we're not quite there yet.
I think that's another big thing that even parents probably are wondering about, like if they've had kids that are, nowadays I feel like so many kids are in a lot of competitive sports very early and, maybe exposed to concussions early on. Is it something that they need to rethink about what sport they're playing later on, especially for like parents that are listening?
Yeah. I think, people always ask how many is too many.
Right.
There have been some studies that show that if you've had 3 or more concussions, you're more prone later in life to develop a neurodegenerative disease, Alzheimer's, seizure disorder, different types of dementia.
Right.
And so that number of 3 is kind of thrown out there.
Yeah, I've heard that too.
But I think you have to take each case on its own merits. If somebody had a concussion, when they were 4 or 5, and then was able to play sports and never had another concussion until maybe they were 18 or 19, is that person really like a first-time concussion person? Or is that person, do you count that first concussion and now you've had a second? So I think you have to take everyone individually. You have to evaluate them individually. But one of the things I would say is sometimes having one concussion, we would make a recommendation for retirement. If they had post-concussion symptoms for 2 months, 3 months, 4 months, pretty prolonged post-concussion course, a lot of times the athletes don't want to go back to that sport. And then I have other athletes who haven't had severe symptoms from their concussions, and then now they're playing on 5th, 6th, 7th. So if somebody does have a third concussion, or even if they get a second concussion, I start to talk about retirement from contact or collision sports, just to float that idea out there and have them think about that.
Of course, yeah.
And then, generally at Webner, when we have an athlete that's had 3 concussions, we sit down with them outside of a normal appointment and talk about the risks and talk about, and say, hey, it's okay. You have support here. It's okay if you retire from contact or collision sports. That's been effective at kind of helping people decide what the right thing for them is.
And that's got to be hard because again, when you're an athlete, it's part of your identity, so it's a big identity crisis, whether it's an injury, ACL, whatever, that takes you out of your sport and you're like, what do I do next? And how do I go from here? I even think about DeMar Hamlin and even like a Jason Kelsey, that just had repetitive hits over the years. And it's like, did anybody at any point have to have that conversation?
Yeah, look, you've seen guys in the NFL that have retired early, right? Calvin Johnson, the wide receiver from Detroit. He retired after 9 years. He was at the top of his game. The folks are concerned about post-football life, right? You want to have a life post-football. And so a lot of, you'll hear it every year. 1 or 2 or 3 folks retire early because, they've put their time in and they don't want to, have that experience.
Sure, absolutely. So other than concussion, are there any other areas that you typically treat the athletes for?
Yeah, like I said, I do a lot of tendinopathy treatments. So anything from common extensor tendinopathy, which is also known as tennis elbow, medial flexor tendinopathy, which is golfer's elbow, rotator cuff tendinopathy, chronic tendonitis, which we call tendinopathy. We know the term tendonitis is kind of a misnomer. It means acute inflammation of the tendon. And most of these people who have pain more than 2 or 3 weeks, it actually becomes tendinopathic. So instead of the normal tendon looking like this, you get scar tissue that interposes itself, and that creates a whole different kind of pain cycle. And you guys know in physical therapy that, what ways to treat and tendinopathy is to strengthen that muscle, to stretch that muscle, to help the muscles around it become stronger, and then also to do some manual therapy to try to break up some of that scar tissue with ART, Graston technique. So I treat that. And like I said, we use the debridement procedures that we do, either ultrasound guided percutaneous tenotomy, which is just with a needle to break up some of the scar tissue.
So cool.
And then with these 2 tools, we have one that's like a power washer, that's a long probe that basically under ultrasound guidance, we go into the scar tissue. And it's kind of like a high pressure water jet that breaks up the scar tissue, then sucks it out. That's 10-jet. And then 10X is also a probe, but it has like an ultrasonic heat element on the end of it. It kind of melts the scar tissue and then sucks it out. That was kind of founded out of the ophthalmological arena, where they used to use that type of technology to help with cataracts. So that would be the way that they kind of emulsified the cataract and then kind of took it out.
I know that. I was going to so how is that with fairly new treatments?
It's been around for 10, 12 years.
Wow.
Yeah, so they've been around for a while.
So interesting.
And then we do it under ultrasound guidance in the OR. Generally for elbows, I just do local anesthetic. We make a small incision. We go in with the tool under ultrasound guidance. We break up the scar tissue.
Sure.
It takes about 3 to 5 minutes.
Sure.
I'll also, do light sedation or conscious sedation, same kind of thing you get when you get a colonoscopy. I also do that for shoulders and patellar tendon, Achilles tendon. Those are kind of more painful procedures. So we'll do those as well, plantar fascia.
Okay.
And so, so that's some of the other tendinopathies that we see in practice. Yeah.
Excellent. And you said you work with physical therapists on that realm through Virtua as well?
Yeah.
Awesome.
Virtua. And then, in South Jersey, I have a lot of physical therapy places and physical therapists that do a really nice job that aren't necessarily employed by Virtua. So I have a whole team of folks that we work with. Yeah.
And same with the concussion management too?
Yeah.
Nice.
Yeah,
Excellent.
absolutely.
Excellent. Very cool. Well, Dr. Webner, this was so great. And I'm so glad that you were able to come in here because I do know that there's going to be a ton of listeners that are so excited to learn all about you and what you do. All the Union fans, the Webner fans. It's going to be awesome. Yeah. Is there any other advice that you have for maybe you're an average Joe, a child, for their parents, if they're suspecting a concussion, kind of next steps if they're not, who to contact?
I think first, a good person to go to first is always the primary care physician.
Sure.
So they've been trained in managing general kind of concussions and neurological issues. So I think that's the good person to start with. For kids, you could always start with your general pediatrician as well. I think that's probably the first kind of gatekeeper, so to speak.
Awesome.
For kids at school, athletic trainer, right? So they're the gatekeeper there, and they can kind of talk to the parents and kind of, they've seen a lot of, sports injuries. So I think, they're very well versed by the time they're a certified athletic trainer in kind of triaging those injuries. Okay.
And then where can our listeners learn more about you? Do you have a website or anything?
I don't have a website. I'm not really hugely present on social media. But you can find me at Virtua. You can find me on the Virtua website. They probably have some information.
Some little blurb.
Yes, some little blurb on me.
Excellent. Well, thank you so much for your time. This was awesome.
Yeah.
And I appreciate everything you talked about.
Thanks.
Excellent.